Sleep disorders affect around 30% of individuals, with this rate increasing among people with disabilities and chronic conditions. Despite sleep disorders being common, many traditional rehabilitation clinicians do not address sleep. Occupational therapists were uniquely positioned to evaluate and intervene in this critical area, but many of us lack the specific tools and confidence to do so effectively. Today we'll bridge the gap by discussing why sleep is important, as well as evidence-based strategies you can implement immediately to transform your clients' outcomes through better sleep. Welcome to the Health Coach OT, evidence-based coaching tips and resources for managing chronic disease and rehabilitation. I'm your host, Dr. Jaclyn Schwartz, occupational therapist, scientist, board-certified health coach, and educator. This is where we expand the traditional boundaries of rehab to address the root causes of chronic disease, where we build the evidence-based skills to address lifestyle factors like nutrition, physical activity, and more. Using an inclusive and intuitive lens, we meet people where they're at in their health journey to create lasting outcomes. To introduce an expert who brings specialized knowledge to our conversation about sleep assessment and intervention through an occupational therapy lens. Our guest today is Louise Berger, a qualified occupational therapist specializing in sleep medicine with a passion for helping individuals improve their sleep. Louise established the insomnia service within the sleep clinic at the Royal Surrey County NHS Hospital over 12 years ago. Under her leadership, the clinic has grown in size, reach, and reputation through providing tailored one-on-one sleep interventions for some of the UK's worst sleepers. As a committed advocate for sleep health, Louise acts as an associate lecturer on the University of West England Sleep Medicine course. She's a trustee for the British Society of Pharmacy Sleep Services. She co-edits the British Sleep Society newsletter and works as a sleep coach for the global online coaching company BetterUp. What makes Louise's perspectives particularly valuable for our audience is her commitment to positioning occupational therapists as ideal providers of sleep interventions and her practical experience integrating sleep assessments and treatment into clinical practice. I'm excited to dive into our conversation with Louise about the often overlooked role of sleep in rehabilitation outcomes and how OT practitioners can expand their practice to address this crucial area. Please join me in welcoming Louise to the show.
Hi, Jaclyn. Thank you so much.
I'm excited for our conversation today. One of the key indicators for lifestyle changes is the American Heart Association Life Essential 8. And so there are these 8 things that you can do to live a healthier life, which improves your heart health and your stroke health and diabetes and all the things. But I think I got maybe one lecture on it in OT school, and that's probably being generous.
Yeah, I don't think I got anything actually.
Oh, okay.
Yeah.
I'm glad I'm not the only one. Can you tell us why sleep is so critical, particularly for the people that we see as occupational therapists?
Yeah, absolutely. Well, sleep is something that we just cannot survive without. Because every function within our body is dependent on our ability to sleep in order to operate well during the day. Actually, it just has a really profound impact on us when we're not sleeping well. So we know that sleep is important for our physical health and our well-being, our immune system, cardiovascular health, or everything in terms of physical, both short-term and long-term, but also in terms of psychological health. Actually, when we haven't had enough sleep, we tend to become less able to regulate our emotions. We tend to adopt more of a negative bias because of that, and then that has an impact on our relationships and our interactions with people. Equally, our cognitive performance, things like concentration and memory and our decision-making ability are all impaired by inadequate sleep. Then we can look as well at societal impacts and health service impacts, that actually there's a huge financial cost to poor sleep, in that it's probably aggravating every other health complaint. So we tend to use health services more. We're more at risk of accidents. So it's just a really huge impact on everyone. And then, of course, as soon as we have another comorbidity, whether that be a mental health condition or a physical condition, actually that's going to mean that sleep is more likely to become a problem. But equally, it's super important that we're able to address those difficulties to help with our recovery or just coping with life, really. Sleep is just fundamental to our quality of life. It is so lonely and even scary when we can't get the sleep that we need. it really does make it hard to enjoy life, and everything feels like a battle. And many of the people we're working with, they've already got that problem for multiple, it might be because of pain or joint issues or anxiety. They're already having their quality of life impacted. Yeah.
I just want to make sure I have the terminology right. So there's sleep and then sleep disturbances and sleep disorders and insomnia. Can you tell us a little bit about the different terms?
Yeah, really good question. Yeah, so obviously we all have an experience of sleep, and I think maybe this is one of the reasons why sleep has in many ways been neglected through history. And in terms of medicine, my understanding is it became a recognized area of medicine in the 80s, but actually that means it's quite a new field. So sleep disturbance would be essentially any disruption to our sleep, and sleep disturbance is really normal. If I were to have a coffee in the late afternoon, I would very quickly notice that my sleep was being disturbed. If a fire alarm goes off in the night, or maybe if we're experiencing some sort of stress, it would be normal for us to experience some sort of sleep disturbance or disruption, as in not what feels like the sleep we're used to or we need. Sleep disorders are when we're getting into that area of something being probably quite chronic, so enduring for a certain period of time. It may well be quite regular, as in happening more than just once a week or so. In terms of insomnia, we tend to look for three nights per week. Also, intensity-wise, it's probably at the point where it's going to be causing some sort of disruption to our daytime functioning, or even causing distress. So if somebody is sleepwalking occasionally and it doesn't particularly bother them, we wouldn't really consider that a sleep disorder. But if they were really struggling to function over the course of the day and they were putting themselves at risk safety-wise, and it was happening fairly regularly, then that would be considered a sleep disorder. I guess you asked about insomnia as well, which is a really great question, because it's one of those words which is really overused a little. And really we have insomnia as a symptom, and then we have insomnia as a disorder. So it's quite common for people to have maybe a bad night in the week, and they might say, oh, I had insomnia last night, or I've got insomnia. But actually that wouldn't necessarily be what we consider to be insomnia disorder or chronic insomnia. A little bit like we may feel low in mood sometimes, but we wouldn't assume that actually we're depressed if that was happening in response to something quite specific and not enduring. So insomnia disorder is something that essentially has been going on for 3 months or more, and it's a difficulty falling asleep or getting back to sleep, which tends to result in low sleep efficiency, as in the amount of time somebody's in bed, sleeping versus in bed, is quite low. So you have to have the sleep opportunity for your sleep problem to be considered as insomnia. And so difficulty falling asleep, staying asleep around 3 nights per week for 3 months or more, to the extent that it's having an impact on our daytime performance or our experience of the day, often causing some level of distress.
So it sounds like the actual hours of sleep are maybe less important than its impact on your daily activities.
Yeah, so it's really interesting, because actually the diagnostic criteria do not give us any specific hours. That somebody who only sleeps 6 hours has insomnia, but if they're sleeping 7, it's fine. It doesn't even say how long somebody has to be awake during the course of the night. And this is an interesting element of insomnia, that firstly, it's diagnosed on the basis of subjective report. And secondly, we know that people's experience of their sleep can be quite different to what we record in lab polysomnography. So it's one person may feel that waking, or I don't know, maybe taking an hour to fall asleep is utterly hideous, and it completely, rules their life and their day, worrying about this, even though they're then getting 7 hours sleep after that. Whereas another person may come along and feel like they're only sleeping maybe 5 hours and be far less distressed with it. Furthermore, we know that often when we are concerned about our sleep, we tend to underestimate it. We pay more attention to it. So we have an attentional bias there, which means we notice the wakes, we're thinking about them, and then we're evaluating them during the day, adding up how long we've slept, and often then this feeds into a cycle of anxiety. So when we get people into labs, often we find that they've theoretically, on paper, using the machines, had more sleep than they believe that they have had. Equally, good sleepers tend to overestimate their sleep because they're not paying attention to it. So there's a very strong sort of subjective element to insomnia, and that doesn't mean to say that people who people who say they have insomnia don't have a sleep problem, because almost definitely they do. It's just that we know that sometimes it's not quite as it feels like it is.
That sounds very aligned with occupational therapy because it's looking at
Yeah.
how it impacts function as opposed to just being something consistent with like a specific set of rules, and it takes into
Yeah.
account the client's perspectives on what's
Yes.
happening in their life.
Absolutely. Absolutely. And recognizing that if that particular element of that person's health, whether it be their sleep, whether it be something else, is causing them distress, then actually that is eventually going to have quite a negative impact on other things. So it is worthy of attention for that reason alone.
So what are the type of things that might cause insomnia?
Yeah, so this is a really, really good question, and I think it's really diverse. Generally, in terms of how insomnia develops, we think about it using the 3Ps model. So this is Spillman's model, and actually I've seen this model now it was developed for sleep, but being applied to other conditions as well. So we think about sleep and insomnia in particular in terms of predisposing factors, precipitating factors, and perpetuating factors. So predisposing factors might be those factors that mean that we're slightly more vulnerable to developing insomnia. So if somebody is a type A personality, for example, or they're just naturally quite an anxious person, then they're probably a little bit more likely to experience that. But that by itself doesn't actually push them into poor sleep. What we think usually is required is a precipitating factor, a trigger. So this may be some sort of stressor, as in ill health or worry about a presentation, financial issues, change of job, whatever it might be, which tips that person into those first few bad nights. And for most people, about 90% of people, if they're experiencing short-term sleep disruption, then actually that will go back to normal within maybe a few nights, maybe a few weeks, so fairly quickly. But we know that for around 10% of 10% of people, it's like the sleep problem gets stuck and keeps on going. It's a bit of a vicious spiral that's a little difficult to get out of. So this is where the perpetuating factors come in. Those factors that may actually mean somebody doesn't get back to their baseline and ends up with ongoing poor sleep. So when people are in this position, often they start worrying about their sleep. And then, of course, if we're worried about our sleep, it means that our stress response system, our sympathetic nervous system is activating come nighttime, and then it's going to be more likely that actually we struggle to sleep. Equally, often, in order to cope with the lack of sleep, we change our behaviors. So it's not uncommon for people to extend their sleep opportunity in the hope that if I just go to bed earlier, or if I just lie in, I'll give myself that chance for more sleep. But of course, then we're changing something about our routine and risking getting into bed before our body is ready for sleep, which then means that we don't fall asleep, we get stressed about it, and then sleep is even worse. It might be that we start drinking more caffeine during the day, which of course is a stimulant. It blocks the adenosine, which we need for our brain to know that it's feeling sleepy. And then, at nighttime, we might have more alcohol. We might cancel going out with friends because we don't want to stimulate ourselves in the evening. So there's this sort of big response, which is partly psychological and partly behavioral, that we think of as a shift in our sleep attention, and intention to sleep better, and effort to sleep better. Whereas the problem is that sleep is an automatic process, and it generally works far better when we're not paying attention to it, because we can't control it. We can only create the right conditions. So these things tend to make the sleep worse.
Yeah, that's a really helpful model to think about the causes of insomnia and work through it using your clinical reasoning. And so when you are working with clients, how do you identify someone, maybe not in the sleep clinic where you're working, but like in a typical setting, how might you identify someone who would benefit from sleep intervention?
I think the starting point is asking them. And even as OTs, as wonderful as we are and the amazing work that OTs do, I don't know that many OTs routinely address sleep. And this is really common amongst all healthcare professionals. And I think there's a number of reasons for that. Part of that is lack of confidence. Part of that is because historically society hasn't particularly valued sleep, and particularly if we look within healthcare, shift work is a normal part of a lot of healthcare. I know as OTs we're probably doing that less than maybe our nursing or medical counterparts, but equally if we all stood up to the fact that we value our sleep and no, I'm not sacrificing my sleep for my work, then our health services would crash and burn.
Yeah.
So there's kind of a culture of not worrying too much about sleep, or maybe ignoring it. So yeah, the starting point would be asking. And I think there's two fairly easy questions that we can ask just to open a conversation if somebody hasn't actually mentioned their sleep. And that would be, do you regularly find that you're having trouble with your sleep? So identifying whether there are any nighttime issues, and equally, do you regularly find that you have trouble staying awake during the day? So looking more for those daytime components. And those two questions tend to be fairly good at opening the door to further conversation. And we do see that sleep, I guess being aware that sleep presentations are different. I find it really intriguing how when it comes to sleep, we have a very different approach than we do to other medical disorders or problems. So it's really common for people to approach me and say, oh, Louise, I'm having some trouble with my sleep. Can you give me some top tips? I've even had this from other medical professionals. So during COVID, the long COVID clinic, sent me an email to say, Louise, we've noticed that many of our long COVID patients seem to be struggling with their sleep. Can you give us some top tips to fix it or to help them? Now, while I absolutely applaud their openness and their spirit of wanting to help, at the same time, can you imagine if the reverse were true? If I went to the long COVID clinic and said, hey, long COVID clinic, I've noticed that a lot of my insomnia patients seem to also be suffering with long COVID. Can you give me some top tips? And they would probably be horrified, because long COVID is a complex problem. And actually, it requires investigations, and there are all sorts of different treatment options. And I would say it's the same about sleep, that actually the starting point is we have to establish what is going on here. And only then can we actually seek to be able to tailor interventions to help people. Yeah, so start with those two questions, and then having a mind to, is their main problem that they can't sleep even though they have the opportunity? Or is it that they won't sleep? And when I say won't, I'm talking about maybe due to lifestyle that person doesn't have the opportunity. So it's not necessarily a willful won't, but sometimes it is a choice. For example, we do choose to have children, and some people will choose to have several jobs. So is this a difficulty sleeping with the opportunity, or is it a lack of opportunity? That's a good secondary starting point, because if somebody is not in bed long enough, or they are experiencing bedtime procrastination and staying up late scrolling, that sort of thing, that is going to affect their sleep opportunity, lead to sleep deprivation, which of course has its own consequences. For other people though, as much as they commit to sleeping, they still can't sleep very well. And then we're probably looking at the three main areas. Is it more an issue of insomnia? Is it more an issue of them being sleepy during the day? Is it more an issue of things that go bump in the night? And again, those categories subdivide down further. So I'm sorry, I know you don't want me to go into all of those, but just having a sense that they are a bit different. And one of the key features of insomnia in particular is hyperarousal, feeling tired but wired. And people will say, I'm exhausted. I can't think straight. Everything feels like a challenge. I'm just so tired. But I couldn't nap even if I wanted to. And that's a really distinguishing part of insomnia, that actually people don't tend to, or very rarely, experience sleepiness, because sleepiness and tiredness are different. If you're sleepy, you're definitely tired, but you can be tired without being sleepy. Again, we sometimes see this in fatigue conditions where people think things like ME, for example, where people will often spend a lot of time in bed resting because they need rest. And actually, often that can lead to sleep disruption because their need is not actually for extra sleep necessarily, but it's more for the rest side of things. But if you're in bed, you might nod off, and then if you sleep during the day, it's likely to have an impact on nighttime sleep. And before you know it, you've got insomnia thrown in there with the fatigue condition.
So I feel like I have two easy questions that I can go to identify if someone might be having difficulty sleeping. And then we've talked a lot how you want to think about someone who's not just had like a bad night's sleep or just doesn't have the opportunity to sleep, but someone who is in bed, has the time in bed, but just can't fall asleep. And then it's going to disrupt their daily activities. And so that creates a very specific profile.
Yeah, absolutely. And the interventions would be different. A lot of the messaging that goes out, we should all be having 7 to 9 hours of sleep a night. I do question, who's that designed for? Because if you have a sleep disorder, which is not a choice, so, you're not restricting your sleep opportunity, you're trying to sleep, but you can't, then it's not like you can suddenly just read that and go, oh, that's fine now. Then I'll will myself to sleep longer and everything's fine. Actually, that's a really unhelpful message. It's really stressing people out because they read that and think, if only I could get that. Whereas people who are intentionally limiting their opportunity for sleep, actually that might be a helpful message for them to understand that actually you probably need to give yourself more sleep opportunity because it's going to have a negative impact if you don't. So we need to be able to target our messages and take the fear out of the messaging for people who actually have sleep disorders, because it really isn't helpful. It's just making sleep worse.
So the sleep interventions that I've seen are primarily things like sleep hygiene, limiting screen time, Ambien. Are those the only tools in the arsenal for sleep therapists?
No, and it's just so disappointing that is the standard of care, really. There are over 80 different types of sleep disorder. So there's a lot of different sleep disorders and behavioral interventions, of which sleep hygiene is a tiny slice of the pie, as I'd say. It is definitely an important factor for almost all sleep disorders. Even we have good success using behavioral measures for people with slow wave sleep disorders like night terrors or sleepwalking. Equally, they can be very helpful in a package alongside other interventions for people with narcolepsy. So the behavioral interventions are really, really important, I think, probably irrespective of which sleep disorder you have. But on top of that, medication can be used and often is used. And furthermore, it might be devices. So when we think about things like sleep apnea, for example, CPAP is the gold standard intervention for that, continuous positive airway pressure. But for insomnia, actually, sleep hygiene is not effective. it's definitely important to review, but it's a little bit like dental hygiene. We all brush our teeth and we want to keep our teeth in good condition and know that that's important. But once we've got a cavity, we don't just brush harder or use more toothpaste or floss more. Actually, that's never going to be sufficient to resolve a problem. And it's really sad that more healthcare professionals aren't aware that we actually have this amazing gold standard treatment for insomnia. It's referred to as cognitive behavioral therapy for insomnia. That said, it's a little bit of a misnomer because it's very different to CBT for anxiety or depression. It's incredibly sleep focused and it's a multi-component approach, all with a massive evidence base, as I say, addressing the psychological and behavioral factors that keep sleep stuck in a bad place. And for about 80% of people who engage with CBT-I, their sleep will radically improve. It is hugely effective. And certainly within our hospital clinic, we, at the end of treatment, which is usually about 3 to 6 months later, once we've stabilized somebody and they're able to maintain that independently, we will often say to them, if you'd like to leave any feedback on the NHS Choices website, this is the link. And it's nice to have an endpoint. We're really fortunate that we have that. Other clinicians don't have that. And so many people are talking about how life-changing that intervention has been for them after 5, 10, 20, 30 years with horrendous sleep. And all that time, they'd been given sleep hygiene or told it's medicine or nothing else. And it's really not true. And medication should always come secondary to CBT for insomnia. But unfortunately, there's not much awareness of it in spite of so many meta-analyses and the fact it's existed for multiple years, at least 30 years. And there aren't many providers. There aren't that many specialists in sleep really who are working with people with insomnia or circadian rhythm disorders. They tend to fall in the same segment of sleep medicine.
So it sounds like there's specific training for people who want to do sleep all day, every day. And then there's maybe some interventions that we could do as OTs if we have a client. Do you have any suggestions for interventions that clinicians in standard practice settings might use?
No. I think OTs are really well positioned because sleep is very much a function of our psychology, our biology, and our social situation. And of course, as OTs, we have that as one of our guiding principles. It's kind of at the core of our OT model. So actually, we tend to be great people to be able to deal with all those different components. And yes, it is possible, of course, to go and do specific CBT for insomnia training. That would usually be a 2-day training. So it's not a massive commitment. So it might be accessible to some people. But even if an OT felt like, well, I haven't got the money for that, or, I don't really need to invest in that. That's not top of my list, but I'd like to know more. I'd say read up about different sleep disorders, common sleep disorders, so that you can actually be sure what you're dealing with is insomnia, which is far more amenable to behavioral interventions versus maybe a sleep disorder, a breathing disorder, or a sleep movement disorder, or a neurological sleep disorder like sleepwalking, for example. So being aware of the different disorders is really helpful. And then if somebody is experiencing insomnia, there's probably a few key things that any OT can be doing. The first one, as I've already mentioned, is trying to take the fear out of the scenario. That insomnia is maintained by the anxiety around not sleeping. And some of that comes with just paying too much attention to it during the day. Some of it comes from misunderstanding sleep and thinking that actually we should be able to sleep the whole night through without waking. If we understand normal sleep, then we're able to deal with some of those unrealistic expectations. We're also usually able to help take some of the fear out of it in using fairly standard cognitive behavioral approaches. So people will often have quite a lot of all or nothing, black or white thinking. If I don't sleep, I'm going to be a disaster. Actually, maybe unpicking that with them. Well, do you ever remember any days that went surprisingly well in spite of not sleeping? Do you remember having days where you felt absolutely dreadful, even though you did sleep? Try to loosen that attachment to, I can't function if I don't have X amount of hours sleep. Also, what we know is that while sleep is really fundamental to health, most of the studies that we see cited in the media about the physical impact of lack of sleep relate to sleep deprivation, which is different to insomnia. There is a bit of an overlap, but in sleep deprivation, we don't have the opportunity for sleep. Whereas in insomnia, the person has the opportunity, but their body just doesn't seem to be taking it all. So often when people are in the labs, we don't see that objective sleep deprivation that people feel they're having. So trying to take the fear out of it, helping them to become aware that their focus and attention and effort they're putting into trying to sleep is probably making it worse is a really valuable step. Another really easy thing to do is to measure that person's perception of their sleep over the course of a week. So there are some simple sleep diaries. I use one which is based on that of the American Association of Sleep Medicine. So it's on their website, and it's a grid, and it gives you a sort of picture format of sleep over a couple of weeks. If what you can see is that there's a big discrepancy between how long somebody is in bed versus how much they're sleeping, ask them to actually spend a little longer awake, to spend a bit less time in bed. So, if that person is in bed for 8 hours, but they're only sleeping 5 or 6 hours, get them to extend their day by an hour. This is leveraging the sleep system that we refer to as sleep drive. And essentially, it's a pressure that builds up the longer we stay awake. It's a chemical called neurotransmitter called adenosine that's building up in our body. And the more adenosine we have in our body, the easier it is to fall asleep. And it pushes us into the night and fuels us through the night. So by staying up a little longer, actually, or it could be somebody's starting their day earlier. It doesn't have to be later, but essentially truncating that sleep opportunity a little and extending the day, that person gets into bed with more sleep drive within their system, which means they're more likely to fall asleep easily and or get back to sleep more easily when they wake in the night, because it's normal to wake, of course. And then when we do that over a period of a few weeks, what often happens is they start sleeping more efficiently. And then as we start to sleep more efficiently, as in we're awake less overnight and sleeping more, our nervous system goes, oh, I don't need to worry about this so much. Okay, yeah, I was really surprised. Last night I didn't think I was going to sleep, and I did sleep okay. And then, of course, we go to bed feeling a little more confident and a little calmer, which then helps the process, and then in all that, we're helping to re-educate our brain that actually the bed is a place of sleep. It doesn't have to prepare for a battle. And that 1 hour difference I see can make a really big difference. A 1 hour difference in somebody's sleep routine can make a really big difference to their sleep overall. In a clinical context, we tend to go in a little bit harder than that, and we work out somebody's overall sleep time more specifically and put them on a more restricted routine, usually. But within a sleep coaching context, where I don't have any sort of medical responsibility for somebody, or when I don't know all the ins and outs of their scenario, I wouldn't be suggesting making a big change to overall time in bed, but that 1 hour can make such a big difference to so many people. So that would be another step I would suggest. I guess the third step that is fairly straightforward as well would be to encourage people not to chase sleep, to try as best as they can not to care at all whether they sleep or not. And that in practice turns into, if you can't sleep, accept that you're not sleeping. Give up trying to sleep and give yourself the opportunity to do something else, whether that's the start of the night, the middle of the night, or towards the morning. if you're, but you don't have to do this if you're just having one bad night and you usually sleep well. I'd say don't worry about it at all. But if the problem is insomnia, where somebody is probably at least half the nights of the week and it's been going on for some time, struggling to sleep, is just to get up and do something else. And if somebody isn't physically well enough to get up and do something else, fine. Get them to sit up in bed and do something else. I mean, we believe that the ideal is getting up and away from the bedroom, but a lot of the power in that technique is the saying, okay, I'm not going to lie here. I'm not going to continue with tossing and turning and counting backwards with 100 and from 100 and praying and all of those things people do when they can't sleep, trying to force it. I'm going to stop the effort. I'm going to sit up or get up and do something else until the point when I feel like I can't stay up or stay awake any longer, and then go back to bed. And for some people, they will do that and they will fall asleep, and that all happens more quickly than it would if they were just in bed trying to sleep. If they just stayed there, they might take 3 hours to get to sleep. But by getting up, they're up for half an hour, get back to bed and asleep within an hour, which is great. For other people, they will do that and find that initially it doesn't seem to be particularly effective. But of course, there's an accumulative benefit over the course of several nights and maybe into a couple of weeks, that in that time we are sitting upright, we are most definitely awake, which means we are rebuilding that adenosine, we're rebuilding our sleep drive. So we're acquiring a little bit of a sleep debt, which then enables us to sleep better in subsequent nights. So it's very much, I'm doing this today for my sleep in a week or two's time rather than for right now.
So it sounds like the take-home message for that is be in your bed when you're sleepy, but if you're not sleepy, maybe wait to get in bed.
Yeah, absolutely. So yeah, there are more interventions that I haven't spoken about but link with that. Absolutely. Just trying to be aware, am I going to bed because this is the time I've always gone to bed? Am I going to bed because I feel physically exhausted, but my mind is buzzing? In which case we're probably going to have some difficulties with sleep, and it would be better just to stay up a bit longer and wait until we feel sleepy, keeping the bedroom for sleep as much as we can as well.
One thing I really appreciate about your story is how you've been able to really grow the sleep service. And so here in the US, we haven't traditionally addressed sleep as much as maybe we could have. Do you have any advice for practitioners who might need to overcome barriers like productivity, or just like, we've never done this, or we don't have buttons for it in our documentation system? How do you overcome these barriers to grow the sleep practice, or to even start addressing sleep?
It's a really good question, and I think it is difficult. It's okay to start small scale, and if you can maybe do some sleep interventions, even if they're quite short and brief with just a few people, and measure the outcomes and get their feedback on that, then hopefully that's going to put you in a stronger position, one, to feel more confident that, yeah, this is the right move, we need to do more of this, but also telling managers or the people who hold the budget that actually this is a really helpful intervention for people. And of course, sleep affects everything else. We know it has such a huge economic consequence, because if somebody isn't sleeping well, their mental health and their physical health is going to be poorer. So it's often hard, I think, for budget holders to be thinking about the longer term impact, but that very much is the reality. I know it's difficult in the States where often things have to be coded for insurance companies. I don't have to worry about any of that, fortunately, and don't have those restrictions. But some people are addressing sleep in the States, and I would say maybe hunt out a few of the more prominent names that you may find on YouTube, or LinkedIn is a great place. And a good space and an active space. I learn a lot on LinkedIn and learn about who's out there, and maybe connecting with them as well.
That's a great suggestion. In terms of continuing education and resources for people who are interested in sleep, you mentioned reaching out to local experts. You mentioned the CBT for insomnia. Are there any other resources or continuing education that would be helpful?
Yeah, so there's a lot of good websites online, and it would be quite straightforward to get a sense on common sleep disorders and how they present from those. So the American Association of Sleep Medicine has an excellent website. I think it goes under the name of sleepeducation.org, I believe, but if you put AASM in, that will come up. There's some good people on YouTube as well. And so someone, for example, like Nishi Bhopal, she's an integrative psychiatrist based in the States, I believe, and she's doing lots of videos to educate healthcare professionals who aren't sleep specialists but want to know more about sleep. And she has tons of free content. She does have a paid program as well, but I would absolutely recommend going to her resources. She's a very accessible speaker and very knowledgeable. Experts, insomnia experts on YouTube, like Daniel Erickson, for example, I think he's got some really fantastic videos. So there's quite a lot you can access free of charge. There will be insomnia education programs or training around, or sleep education available in various places. A lot of it's online. So I can imagine that actually even our UK stuff might be accessible in the States. Start by equipping yourself just so you feel a little bit more confident and clear, and then start with a few techniques. And I know OTs will already be doing a lot around the sleep hygiene remit and around positioning and posture in bed for some of their clients, and around daytime routine and having meaningful activities and all of those things which are also important for sleep, but maybe having a few sleep specific interventions that you feel that you can add on into the mix could be really helpful.
So it sounds like in terms of the main thing to do would be to just start addressing it. And the nice thing about once you start is that people are really satisfied, and that helps it grow when people are satisfied and telling people about their great night's sleep. And then I really appreciated the different intervention tools that you talked to us about, and then also the continuing education resources, both free and paid. For listeners who want to learn more about your work or connect with you, what's the best way to reach you?
So probably the best way is LinkedIn, although I appreciate not all occupational therapists are on LinkedIn. So you could email me, louiseberger@gmail.com. I would do my best to reply to that. Otherwise, yeah, I'm really happy to connect on LinkedIn.
Well, thank you, Louise, for sharing your expertise on sleep interventions and sleep evaluation and OT. We definitely learned a lot. So thank you so much for your time.
Well, thank you, Jaclyn. I've really appreciated the opportunity to just share a little insight into sleep and sleep medicine, which is the name of the field. And I really hope that OTs have found this helpful and feel inspired just to push those doors into sleep a little bit further. It's great work that you're doing. So yeah, thank you. It's been great being here.
That's all for this episode of the Health Coach OT, evidence-based coaching tips and resources for managing chronic disease. Thank you for listening. If you found today's discussion valuable, please subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts, and leave us a review. For free resources, visit healthcoachot.com and join our newsletter for weekly insights and updates. Until next time.